I apologize for having to continue with incontinences on a separate lecture. I must have hit something when I was doing the previous lecture, so I'll just continue here. We've talked about the main types of incontinence. There's also overflow incontinence, which we talked about somewhat with patients who have urethral strictures, okay? If you go back to kind of understanding urethral strictures, many times they can occur because of a side effect of STDs. Sometimes urethral strictures can occur because an indwelling Foley catheter has been in too long of a time. Or maybe a stricture can occur from, as I said before, an anomaly or you were born with some kind of deformity in that area, or else maybe some kind of residual effect from a complication. But with a stricture, you can actually have overflow incontinence, where the detressor muscle fails to contract and bladder becomes overextended. Because remember, with a stricture, you can't void properly, and so you're going to leak out urine to prevent bladder rupture. It's kind of a defensitory mechanism that the bladder kind of senses, hey, you're not able to go on your own, so I need to, use the measures I can to prevent this bladder from distending so much that it could actually cause a rupture. And there's other factors too that can cause urinary incontinence. Some of your disease process. Patients had a CVA, some of your neurological disorders like Parkinson's, even patients who become depressed without inadequate resources, such as eyeglasses, canes, even financial means to be able to toilet properly, and one who really does need assistance to the bathroom. Those can also contribute to somebody becoming incontinent. Even immobility, they've got to go from place A to place B, and if it really is a difficult situation for them to get to the bathroom, guess what? They don't get there on time and they become continent, which can really deflate one's self-esteem. And that's our concern with frequent incontinence. It's embarrassing. It causes people to become very recluse and kind of stay within their house, and to become very antisocial because they're just afraid to go out in case they have some kind of an accident. It can be very embarrassing to have wet clothes, as well as the smell associated with urination. And I talked about total loss without warning, treatment, usually absorbent undergarment, catheters, and of course overflow. Sometimes when the bladder is not completely empty, that's another cause of overflow. And you want to make sure too that when your patients do have Foleys, that the Foley is draining properly, that there's no obstruction causing that bladder to kind of fill up and having the potential for a bladder rupture. The Creed maneuver is just pushing down on the abdomen to kind of get the flow started. That's exactly what Creed maneuver is, and I'll show you that in class. Some of the interventions for incontinence, because it can be very devastating and really change one's social behaviors, is to keep a diary. What kind of diet did you have? Pelvic floor exercises called Kegel exercises, probably one of the most frequent ways to try to help with mild to moderate incontinence, especially with stress. Drug therapy, sometimes giving outside doses of estrogen to kind of strengthen up those perineal muscles. And surgery may be an option if the person really is having severe and more frequent bouts of incontinence. May be necessary to do like a cystocele rectocele repair. Vaginal cone therapy is when it's different sizes of cones are kind of inserted into the vaginal wall to kind of bear down and squeeze on these cones to kind of help strengthen those muscles around the urethra to hopefully improve the incontinence that's occurring. Obviously, surgical management could be an option. And many times when the repair is done, a person may have a suprapubic catheter, which is a direct catheter into the bladder rather than through the urethra. That may be in for a few days post-op during the healing process. Some of the more common interventions for incontinence are the pharmacological interventions. Many of the medications that are out there to help control incontinence. Because even with hormone therapy, it may take up to 4 to 6 weeks before a person really feels like, hey, they've got some control over their bladder. Some of the antispasmodics, such as ditropan, which I have up here on the PowerPoint slide, can cause bladder muscle relaxation, and but unfortunately, some of the side effects with that is it can increase intraocular pressure and really give a person a dry mouth. So you might want to alert those people if they're put on some of these medications that these are some of the side effects. Some of your anticholinergics, such as Detrol and Visicare, it is not recommended that these are used with BPH. What it does is how it works, it increases volume capacity, and it suppresses those involuntary bladder contractions. And you'll see this commercial on TV where the lady's holding the bladder's hand and kind of leading them to a bathroom all the time. Some of the most common side effects with your anticholinergens, such as Detrol, your cholinergics, is constipation, and again increases ocular pressure. Okay, your alpha adrenergic agonist increases contractile force of the urethral sphincter and increases resistance to urine outflow, and that's midorine. Wouldn't use that necessarily with someone who has high blood pressure because it can cause hypertension, and it's recommended that this particular medication or even these groups of medication are not used with cardiac patients or cardiac disease. Some of your beta blockers like Vibetrig is also affects blood pressure, and how it works is it just relaxes the detressor muscle so it doesn't spasm out and cause you to have that incontinence where you have an overactive bladder. Be careful when patients are put on this. It can interfere with the effects of Coumadin. And also some of the antidepressant medications, Tofranol, Elevil, work well with incontinences, but again, assessing patients' blood pressure that it doesn't cause another problem as one of the side effects with these medications. And again, some of the other interventions, this is reflux, just kind of functional. I'm not going to go over these again. Two common types of problems that we see with the bladder is spastic and flaccid. Your spastic is more the most common type. It can be caused by a spinal cord lesion above that voiding reflex arc. And what happens with the spastic bladder is it kind of empties on reflex with minimal or no controlling influence to regulate its activity. So it just kind of is very spastic and just kind of spastics out and kind of makes you have incontinence at will. Flaccid is really has to do with more lower motor neuron lesions, commonly from trauma. We see this a lot in our patients who have had long-term diabetes. Bladder continues to fill and become distended, and then you have overflow incontinence. And what are concerned with flaccid bladder is infection. That's one of the big complications. They use urocoline to increase the contractions of the detressor muscles. So that's basically spastic and flaccid bladder. Okay, just think about a muscle that's very flaccid, just really has no integrity or spunk to it to give it its ability to control that bladder. Because think of the bladder, it's a muscular structure, and when it's flaccid, excuse me, it's kind of limp. Spastic, think of what happens when you have a spasm. It's kind of spasm and squeezing that urine out just uncontrollably, causing the person to urinate at will. So those are neurogenic bladders. Sometimes a patient may have perception of fullness, the need to avoid bladder emptying. You know, how we urinate and feeling that the bladder's full and emptying are all controlled by the central nervous system, okay? And usually we get that stimulus to urinate when the bladder has about 400 milliliters of urine, and this is what tells our brain, hey, you need to urinate because the bladder is getting full, okay? So I think that's really all you need to know about spastic and flaccid type of bladders, okay? But, you know, we see this a lot in patients with, you know, neuromuscular diseases, as I said, with diabetes. Sometimes patients get in automobile accidents. Some of our patients who have spinal cord damage with paralysis, we see this very often in a patient that really has poor control over their bladder. And many times with neurogenic bladders, when that person is ready to urinate, when they have that abnormal sense of urination, they might sense, oh my goodness, I'm going to urinate, and might have a associated manifestations of diaphoresis, flushing, or even nausea prior to the reflex incontinence. And as I said before, uricoline works nicely with a patient who might have flaccid bladder. All right, now we're going to talk about kidney stones or urolithiasis. Okay, what this is the presence of stones in the urinary tract. They don't cause symptoms until they actually pass into the urinary tract, where they can cause unbearable pain. And our concern with this is if they're big enough, they can get lodged, particularly in the ureters, cause damage to the structure itself, and become an obstruction to prevent proper urinary flow. Urine can retrograde back up into the kidneys and cause some serious situations. So these are very serious problem in the urinary tract system. And once a person develops kidney stones, they're more prone to develop more later on. That's why it's really important, if that is our suspected diagnosis, that we try to strain all urine and analyze these stones to see if they're diet related or whatever the case may be. Nephrolithiasis is the formation of stones in the kidneys, and the exact mechanism of why these stones form is pretty much unknown, but most of these stones contain calcium as one part of the structure. They either have a very high, usually patients that have, or people that have very high acidic urine or very high alkaline urine are more prone to kidney stones. Remember, one example is an excessive amount of calcium that is absorbed through the intestinal tract, and this causes a supersaturation of calcium in the urine, and when someone is dehydrated, it will cause most likely for supersaturation to occur. That's why we really encourage patients with any problems with calcium to really drink a lot of fluids. If you go back to your patients with endocrine problems such as hyperparathyroidism, where they had high calcium levels, what was one of the interventions? To drink a lot of fluids. Stones that form in the kidney will then pass into the ureters in a place where the ureter bends or slightly changes shape, okay? And that's usually where they begin to lodge at, okay? We see about 320,000 hospitalizations a year for kidney stones. More men than women experience kidney stones. And like I said, it could be related to nutrition. That's why it's necessary to really encourage someone who has had a previous history of stones to drink a lot of fluids and really have a good output, at least 2,000 mLs a day. Some of the foods that are high in calcium, uric acid, cysteine stones or oxalate stones, we would really kind of do some dietary teaching with these patients, because that could be the reason why there are forming more stones than usual, and definitely acquiring them. And our concern with stones is, first of all, when they lodge, particularly in the ureters, they can cause spasms. And some of this pain associated with kidney stones, I heard, is extremely painful. Could also bring a shock to stimulating nerves, and some of this pain is so intense that it can actually make people, diaphoresis, and then of course pass out. Along with those stones, when they're big enough, when they're lodged in those ureteral linings, can cause hematuria and damage to those linings. And if they're not removed, obviously a great source of infection. So first of all, we want to focus on the pain, get those patients feeling a little better, and then we want to prevent infection and remove that particularly obstruction. And this will be diagnosed by many of the diagnostics that I talked about on the previous lecture, maybe a KUB, a CAT scan, or whatever, to definitely diagnose that the patient does have a kidney stone. So they're going to need some very strong pain medication, usually opiates, Toradol. Be careful of NSAIDs, because it could put the patient at risk for further bleeding, teaching them to relax, putting them in a quiet environment, and it helps make the passing less painful. And when we suspect a kidney stone, if they're in the hospital, we really want to carry out the procedure of straining all urine. Why do people get these? That's a great question. I talked about some of the theories behind it, but sometimes it can be related to personal or family history, genetic predisposition toward the accumulation of certain mineral substances in the urine, patients that are dehydrated or immobile, excessive diet of calcium, oxalate or protein, people that have obviously hyperparathyroidism, gout, and urinary stasis. Obviously, symptoms will vary depending on the size and location. If they're in the bladder, patient may not even know that they have a stone. It's when they start moving out into the ureters, and maybe other correlated or associated symptoms such as gross hematuria may be an indication that a stone is up there, but they may not have any pain with it. When they're in the kidney, it can be very asymptomatic. Sometimes the patient may feel a dull, aching flank pain, microhematuria, just kind of typical manifestations of a UTI. But when it gets in the ureters, it can cause spasms, severe flank pain on affected side, and really starts to have what we call renal colic, and can radiate to the suprapubic region, where the patient becomes very pale, nauseated, and vomit. Okay, so these are some of the very classic symptoms of kidney stones. And sometimes just heat to the affected area also helps soothe some of the very, very serious pain associated with kidney stones. Okay, so what are we going to do to fix this? What are we going to do to get that large stone out that really would be very difficult for a person to pass? Obviously, pain first, and then we do a procedure called lithotripsy, which I'm going to talk about in a very couple minutes. Sometimes, if that is an unsuccessful procedure, may have to do surgical management, even minimally invasive surgery, as well as open surgical procedures to definitely relieve that patient of their kidney stone. So the first thing that's probably one of the most common treatments for kidney stone is extracorporeal shock wave lithotripsy. We kind of use the acronym ESWL, and what we do with this is they are basically sound or laser or dry shock waves to break the stones into small fragments so that it can easily be kind of excreted outward. Okay, and what happens with this is a person is taken to a particular room. I'm not sure if they take them to surgery. I've never been involved in a lithotripsy, but the patient will be in a very controlled environment. They will be on a cardiac monitor. They will get a little bit of sedation, and what they do is they actually apply a cream 45 minutes before the procedure, and they'll put the lithotripter aimed at the stone, and that can be located by a fluoroscopy to know exactly where they're going to aim that sound wave at. And it's important that the patient blood pressure and of course their cardiac rhythm is monitored, and then it's got to be very forceful in order to break up those stones. So that's why we're concerned about the effect it could have on the cardiac system. And after the procedure, if it is successful, if it actually does break up the stone, the area where those sound waves or laser or dry shocks were aimed at, you might see a slight bruising at the site, and we'll just keep an eye on that because there is some kind of a little bit of trauma to the vessels. We might want to put a little ice on that, but we want to watch the area to see that there's no further bleeding. Also be aware of what medications your patients are on. Maybe if they're on Coumadin, I'm not sure if the physician would stop that until this procedure is over with to kind of lessen the effects of bruising. One thing to know with lithotripsy is that cystine type of stones are very resistant to ESWL. So if we know that this particular stone is made of the material cystine, it will not be very conducive to having this particular procedure work. Okay. And I just wanted to go back to if this is a unsuccessful procedure, there may be other means to help rid the patient of the kidney stone stents, cystoscopy, a nephrolithotomy. And what that is a percutaneous nephrolithotomy, where they actually go in to the area where the stone is and actually remove the stone in that way. So that is other interventions that we can do if this lithotripsy is not successful. Excuse me. If we do identify what the stone is made of, we might, again, as I said before, include dietary teaching about what foods to avoid. If the stone is made from calcium oxalate, a lot of your foods like spinach, black tea, and rhubarb have that particular nutrient in it. Calcium phosphate, animal protein, decrease calcium intake, milk, and other dairy products. If the stone is made of struvite, magnesium, and ammonium phosphate, we would encourage the patient to limit high phosphate foods such as dairy products, organ meats, and whole grains. And with uric acid, decrease purine sources such as organ meats, poultry, fish, gravies, and red wines. So know that, guys, because that's very important that we teach our patients that, because if they can modify their diet, they may avoid a kidney stone in the future. I just want to talk a little bit about the urothelial cancers. Renal cancers account for about 3% of all cancers, 6th leading cause of cancer deaths, 2 times in men as women. Tobacco use continues to be a significant risk factor for renal cancer. Usually comes from the renal epithelium and accounts for more than about 85% of all kidney tumors. And remember, if you do have a malignant tumor in the kidney, it's a very vascular organ and may spread early to the lungs, bone, liver, brain, and contralateral kidney to the other kidney also. Many renal tumors initially produce no symptoms and are discovered on a routine physical exam as a palpable abdominal mass. And hematuria, pain, and a mass in the flank are what start to develop with these tumors. Starts off maybe as painless hematuria in the early stages, and then develops as that tumor begins to grow into more of a colicky pain, and then a person begins to have unexplained weight loss, increased weakness, and develops a lot of anemia. Okay, so also, along with tobacco use, patients that have a high BMI, and as I said before, painless hematuria is probably the most common type of symptom that we see. If we're talking specifically about the kidney, we can see that mass by diagnosis from a CT, ultrasound, renal angiography, and a cystoscopy. Obviously, treatment for a malignant tumor in the kidney would be a radical nephrectomy preferred. Kidneys along with the adrenals and lymph nodes. A laparoscopy would be okay if it was a small tumor. We could take out the tumor that way. Sometimes a renal arterial embolization is another way to go. Kind of cuts off the nutritional end for the tumor to kind of provide an artificial clot. And of course, radiation, chemo, and immunotherapy. With bladder cancer, obviously a biopsy from a cystoscopy, again seeing the tumor through a CT, MRI, and ultrasound. Really depends on the stage. How extensive is this particular tumor in the bladder? Okay, radiation either externally or intracavity, or in the intracavity, and it has been known that the bacilli calmette garian live specimen is given intravesically. It's a solution, bacteria usually used to stimulate the body's immune response to the tumor, and you keep that instilled in the bladder for 2 hours and actually move the patient around so that it can get at that tumor in the bladder, and that seems to work sometimes very nicely for some of our patients. Obviously, depending on how advanced that particular tumor in the bladder is, it might be necessary to take out the full bladder. We see cancer of the bladder occur in patients who are between the years of 50 and 70. Obviously more men than women, about a 4-to-1, more than Caucasians than African Americans, and it's the 4th leading cause of cancer in American men. See about 13,000 deaths a year. Accounts for about 90% of all tumors. Okay, so if it's necessary that we have to remove the bladder, we can either, there's many types of diversions, okay, because remember, think of what the bladder is responsible in doing. It's a storage space, so now we have to create something that kind of holds the urine and kind of do a makeshift bladder type thing. Please note too on the PowerPoint slide the early and the late signs of bladder cancer. Okay. For some of the types of diversions, we can kind of divide them into continent and incontinent versions. Some require straight cathing. The person needs to learn how to do that to themselves, or either an ostomy type of approach in which a person has to learn about the different types of appliances used to care for that particular ostomy. Kind of if you think about a colostomy, we're doing the same thing in regards to the bladder. It would have a bag that would fill up with urine. The ileoconduit urinary diversions, an advantage to that, it's a relatively simple surgery, no need for catheterization, and so what it is just kind of, it's rerouted, probably ureters, to this outside opening in which a bag is put on the abdomen to kind of catch the urine that would flow into that. The disadvantages to this would obviously body image, bag leakage. You know, if the bag gets too full, it could leak out, and then you would have wet clothes. It could be embarrassing and present odors. Also, you're more prone to infections like pyelonephritis, stones, and possible organ damage. Now, your continent reserves are advantages. They're urine reservoirs, okay? So there's no external bag necessary, no odor. Urine leakage is minimal, and all you do is put a Band-Aid that can cover the stoma openings, and reflux is lessened. The disadvantage is this takes a little bit more of a complicated surgical time, but you'll need to actually insert a catheter into the orifice or the hole to cath yourself every 4 to 6 hours, because, you know, we're trying to simulate it as near to a bladder as possible, but you're not going to have that same central nervous system intervention associated with what we do with our normal bladder function, you know, where the brain tells us that our bladder is full. So you're going to have to straight cath yourself, you know, every 4 to 6 hours, okay? And these are like your Indiana pouch, your Cook's pouch. Those are specific types of continent reservoirs, okay, that you would see surgically done to make up for the bladder that was unfortunately removed due to cancer, okay. If these patients do need equipment for their ileal conduit urinary diversion system, they might want to meet with the enterostomal therapist, and also in how to catheterize themselves. You know, that's a very different type of approach to being able to urinate, and, you know, they may want to include family in with this so that they're feeling comfortable in a way to be able to do this on their own. Remember, this is a huge transformation in how one begins to cope with, first of all, cancer, and then the change in the way this function works, which is absolutely huge. There's all kinds of incredible surgical techniques that are done now. With the Indiana pouch and the Cook's pouch is a, as I said before, our continent ileal urinary diversions, and particularly with the Cook's pouch, it's a surgical procedure in which the surgeon actually transplants the ureters to an isolated segment of the small bowel, ascending colon, or ileocolonic segment, and develops an effective continence mechanism or valve. They can also modify the Cook's pouch, attaching one end of the pouch to the urethra, allowing more normal voiding. They can also do a ureter osigmoid ostomy, in which ureters are actually rerouted into the sigmoid colon, so urine is through the colon and out of the rectum. And really making sure that people understand how to care for that stoma, make sure that it's functioning well, there's no infection, and things like that. So it does really take a lot of coping and realization that things are going to be now different, okay? Your book gives a lot of pictures of some of the various types of diversions that are used, either a conduit urinary diversion system or a continent reservoir system. So hopefully that makes sense to you in regards to the surgical management of someone who has to have their bladder removed due to bladder cancer. One thing just to mention is think about bladder trauma. It's a penetrating or blunt trauma to the lower abdomen, may be caused from stabbing, gunshot wound, or other types of trauma. Most common cause is a fractured pelvis with puncture of the bladder by bone fragments, sexual assault, or a seatbelt with a full bladder. So this goes to show you that before you leave the house, make sure you urinate. And not try to be funny, but that's a great rule of thumb. So in case you're ever involved in a car accident, the incidence of bladder trauma is a little bit minimized. Penetrating trauma and unintentional surgeries accounts for about 95% of these types of traumas. And the concern with any type of trauma is to control hemorrhage, pain, infection, and definitely to maintain good urinary drainage. Sometimes you might have, along with bladder trauma, urethral trauma. So that area could be very much affected, and obviously that's where the end, excretion of urine takes place. These are things that we're going to look for if we suspect any kind of trauma in those areas. Assess for anuria or hematuria. Maybe the ureters were severed in the trauma. Inspect meatus for blood. This is when you would do a thorough examination of the urethra. Diagnostic testing such as the VCUG that I talked about earlier. Surgical intervention required unless caused by a contusion. Sometimes if there is repair of the bladder, might include a drain along with a foliar. The patient may even have a suprapubic catheter. Depending on how severe the trauma is, maybe the bladder has to be removed. So that could be a possibility. And then again, talking about what I just mentioned in regards to making some kind of synthetic bladder for a person if the trauma was that severe and could not be surgically fixed or repaired. All right, so this is just a little bit of information. Now we've covered that first PowerPoint, and tomorrow we'll start with some of the care of the patients with the renal disorders. So please, I hope you're listening to these and taking notes and going over the PowerPoints, because this information is very important and you will see some of these questions on the test. So please let me know if you have any further questions. You have a great day, and I'll see you all tomorrow.